Hello, it's Beth again, and I am doing a podcast now on chapter 33, but we're going to be talking about minerals and such. I put such there because we're going to be talking about some minerals, and we're going to talk about electrolytes, and we're going to be talking about medicines that take care of when we get too much of some of them, and so that's why I put and such. Okay, the first one we're going to talk about is iron, ferrous sulfate, and we know that we need iron for hemoglobin, myoglobin, several enzymes have to have it, and cellular oxidation of glucose and antibody for our immune system, antibody production. So iron is extremely important, just like the rest of the vitamins and other electrolytes and minerals we're going to talk about. So got to know our sources. I think everybody thinks about the iron source of liver, beef liver, but those there you can see there's others as well. And so it's important that we teach our patients about that. And deficiencies in this usually ends up being due to someone who's excessively bleeding. Females who are having female problems, if you will, have abnormal periods or whatever. They can bleed in an excessive amount, can definitely have issues there, or iron deficiency anemia. That's another issue that can happen for when we need iron, to take iron. So we need to teach the patients about avoiding one iron salt for another because the amounts may vary between the different products. So we need to watch about that and teach them about it. And it's important to take iron preparations with or after meals because of the stomach irritation. Need to teach folks not to take it with coffee or caffeine because that messes with the absorption. They need to take it with vitamin C, such as orange juice. They need to take iron and caffeine preparations at least 2 hours apart. So the pharmacokinetics, 10 to 15% is absorbed, and I believe that's misspelled, but it's supposed to say stored in the small intestines as ferritin and in the liver. And when it's needed, iron released in the blood is bound to transferrin and transported to the bone marrow for hemoglobin. So it crosses the placenta, and so you'll hear of people taking the prenatal vitamins that contains iron. It's not metabolized but used by cells and excreted in the urine, in the sweat, sloughing of intestinal mucosa cells also. And excess iron is excreted in the feces, and it will turn it a dark color, which is an expected side effect of taking iron, but it's usually harmless. We can give iron PO, IM, or IV. And it is contraindicated, the PO form, for peptic ulcer or ulcerative colitis, regional enteritis, repeated blood transfusions, or where one has too much iron stored in their body. And the main thing with the peptic ulcer and ulcerative colitis, with the PO version of that, it's going to irritate the GI tract. We know already, you've seen that, and so we don't want to already give it give it to something that's already irritated. We want to prevent interactions. Food decreases absorption, vitamin C increases it. Allopurinol, which is a medicine used for gout, increases concentration of iron in the liver. And then, of course, iron interferes with absorptions of quite a few medicines there. Your penicillins, tetracycline, fluoroquinolones, those are all antibiotics. The levodopa is for Parkinson's disease. The methodopa is for antihypertensives. And the levothyroxine is for hypothyroidism. That's your thyroid medicine. For administering, we do not need to crush or chew slow-release tablets or capsules, and with liquid preparations, we need to dilute it with water or juice and drink it through a straw because it will stain the teeth if not. Need to rinse the mouth afterwards as well. And again, avoid food if possible 2 hours before or after to help with the absorption. So we're always going to assess for that therapeutic effects and adverse effects as well. And again, adverse effects is GI discomfort, nausea, constipation, diarrhea, and black tarry looking stools. Of course, the teaching is available in the box 33.3. And again, we need to teach the patient your stool is going to turn dark, could be dark green or black. And, you know, constipation may indeed happen as well. And so we do, you know, need to let them tell their physician about that or healthcare provider, and they can, you know, get something done for that. Now, the iron dextran is the perennial form of iron, and it is used for the peptic ulcer or inflammatory bowel disease because it's going IV. It's not going to have to make contact with the stomach or bowel. Now, there is a black box warning with this anaphylactic reaction, so they recommend that a test dose be done with this. And that's, you know, going to be important to do to make sure nothing happens. And a test dose will be a small amount given to the patient to make sure there's no anaphylactic reaction occurring. The dose is calculated by the hemoglobin and the patient's weight, and it's got a slow onset with this. Again, if we take the PO, we need to drink a lot of water there, and not with caffeinated beverages, and we need to take that with vitamin C to help that absorption. Again, with the IV dose, we do need to have emergency equipment available in the event that you do have an anaphylactic reaction. Now, potassium, KCl. It's used for hypokalemia and also for folks who are taking diuretics. Sometimes you'll see for patients who are on digoxin, which is a heart medication used for heart failure or for atrial fibrillation, because one of the things that's important with the potassium and digoxin is that the digoxin kind of piggybacks on to the potassium to get into the target cells. So our we have to have potassium for that to happen, so it needs to be within that normal range there. And GI problems like excess vomiting, folks may need to have some potassium for that. So our normal potassium level is 3.5 to 5 milliequivalents, and I do want you to know those values. I do want to stress to you that the endings of the lab values that we have, like this one is milliequivalents / liter. Occasionally, faculty will mess up on those endings, but we will never try to trick you on that. So what you need to learn is the values, 3.5 to 5. Don't get caught up in the ending. Sometimes with the like WBCs, you'll see it's, you know, they'll give you a value like at 9,000, let's say. Or it may say 9.0, but, you know, and then it'll give you the ending of, you know, 10 to the 9th power, something like that. And sometimes, you know, when you try to superscript that 9th power part, it doesn't happen. It doesn't carry over to the test. So never think that we're trying to trick you on the ends of those. You just focus on the values, okay? So pharmacokinetics, it's absorbed in the GI tract and it can be given PO or IV. Now, IV is in a large volume. It can be a small bag of fluid, if you will, but never, ever, ever do we give it straight IV push through straight to the vein without, it being mixed in a bag. Because here's what can happen: it can kill somebody. So we never give it what we call IV push or bolus. We give it IV, but we never give it IV push or bolus. And we never give it IM because it is really hard on the veins. So adverse effects is hyperkalemia. So anytime we are giving an electrolyte, we should always check our lab values to make sure before we give that the patient indeed needs it, because you never want to give something if they don't need it, especially something like this, because again, it can kill them. So adverse effects, that it can, when we give electrolytes or minerals too, it can make them have too much. And so we need to know those clinical manifestations. They can have dysrhythmias, heart block, cardiac arrest, respiratory paralysis, and death. Also, concurrent use of potassium with ACE inhibitors, ACEI, or potassium-sparing diuretics, salt substitutes containing potassium, penicillin G potassium. These can do added effect of potassium. So the ACE inhibitors are angiotensin converting enzyme inhibitors, which involves the kidneys, where this inhibits the angiotensin to secrete aldosterone. Aldosterone then causes us to, on a normal patient, causes us to retain sodium and water and excrete potassium. So if we inhibit that, it means that if the ACE inhibitor inhibits that, then that means that the sodium and fluid is going to be excreted, and we're going to hold on to the potassium. Okay, so if ACE inhibitors and potassium is given together, we could really make them be hyperkalemic. Potassium sparing diuretics are diuretics that causes us to urinate. Diuretics cause people to urinate. And these particular kind help make you hold on to your potassium. You don't secrete or excrete the potassium. You hold on to them. So they're referring to potassium-sparing diuretics. Of course, the salt substitutes typically have potassium in them. Again, you don't want to do a double whammy there. And of course, penicillin G potassium has potassium in it as well. So, we don't want to give the patient a double dose there. It is contraindicated in hyperkalemia and in severe renal issues, dehydration, and untreated Addison's disease and heat cramps. So let's talk a minute about renal. When we give electrolytes, no matter what it is, but particularly potassium, if we are not urinating like we should, then that means we're not going to get rid of the potassium like we should. So the patient's going to build up potassium in their body because of the renal problems. So people have got to be urinating. You got to check that. You have to check that. You have to check their renal function. Untreated Addison's disease. So what that is the Addison's disease is about the adrenal insufficiency, and adrenal insufficiency is an endocrine or a hormonal disorder that occurs when the adrenal gland does not produce enough hormones. And the adrenal glands are right above the kidneys, and it can be, adrenal insufficiency can be either primary or secondary. Primary adrenal insufficiency is referred to as Addison's disease, and that is where the adrenal gland's damaged and it cannot produce enough of the hormone cortisol. And we got to have cortisol because that's what maintains a whole lot of our body functions, like our hemostasis. It maintains our ability to handle stress and things like that. So we definitely have to have that cortisol, or our body, we just will not be able to function, both in a cardiovascular way, and also the immune system inflammatory response would not be working right. So lots of issues there. Caution use in renal impaired and cardiac disease as well. So administering the medication, we can mix the oral solution, or effervescent tablets have to be dissolved, of course, and that can help with decreased gastric irritation. We should not ever crush or chew slow release preparations. We take after a meal initially to help with that gastric irritation, and you know, you can try it before meals if there is no stomach upset. With the IV, the maximum amount of diluted KCl is 40 milliequivalents, not to exceed 200 in a 24-hour period. And again, we must monitor our labs, labs being our potassium level. And we have to monitor the ECG, because you will see you know, issues with the changes in the EKG if there is a hyperkalemia. Specifically, the T wave will be elevated, and for hypokalemia, the T wave will be, you know, inverted. It'll go the other way. We always want to assess for our therapeutic effects and our adverse effects. We got to teach. That's important. Not to stop taking the medicine without talking to their prescriber first. Also, if they're taking digoxin or diuretics as well. And not to use salt substitutes unless it's recommended. Serious problems can develop from either too high or too low. And we got to know and recognize those signs and symptoms of that. So hypokalemia can have palpitations, confusion, dizziness, muscle weakness, abdominal distension, frequent voiding of large amounts of urine. The signs and symptoms of hyperkalemia can be muscle weakness, palpitations, slow pulse, fatigue, and shortness of breath. Now, the treatment for hyperkalemia can be the sodium bicarb, and that is used to treat acidosis with hyperkalemia. Calcium carbonate, IV, and of course we got to monitor the ECG there, and it is contraindicated with folks with digoxin. We can also use glucose and insulin, because the potassium to move into cells, glucose is given with the glucose causes the potassium to move into the cells. The insulin is given with the glucose given with insulin is done to prevent hypoglycemia. So we got to monitor the KCl really well there. And then we have the cation exchange sodium polystyrene sulfate, and the trade name for that, I guess, is called K-exolate. You can give that orally or rectally, and it will bind the potassium to stools. So we should be seeing bowel movements with that, and we should be seeing the potassium coming down with any of these treatments here. Okay, so always want to assess to make sure what we're doing is the right thing. So I got you a pictogram here. This one's of the blood work that we need, you know, with potassium, and it just tells you about things to watch for: renal failure, hydration, acid-base balance, cellular damage, diabetes, and watching about the digitalis or the digoxin, diuretics, and IV fluids. Some signs and symptoms of increased potassium there as well. So we want to stay 3.525. And this one talks about how to give the medication IV and PO, and watching about those potassium levels. You must do that before you give it. It's very, very important. Okay, then adjuvant minerals. Magnesium may be one that's used to treat hypomagnesemia, convulsions associated with pregnancy also. And we can see with that depressed CNS, smooth and skeletal and cardiac muscles also depressed. Also used with antacids and laxatives as well, and it can cause diarrhea. Magnesium is contraindicated in renal impaired, and it can be given PO, IM, or IV. The zinc is over the counter, and that can be used for colds and deficiencies. And of course, adverse effects, dizziness, restlessness, nausea, vomiting, gastric ulcers, and diarrhea can occur. And there are multiple mineral electrolyte preps out there, such as Pedialyte, and a brand name as well that contains electrolytes and glucose. And we just need to be careful about renal impairment based on whatever electrolyte may be in the solution. So patient general teaching guidelines for minerals, just general consideration. Again, you're going to see some of the same information that was on the previous one, but we want to always encourage a well-balanced diet, and they should be able to get the minerals needed if that is the case. And the exception may be iron and calcium, where for women and children they may need more. Note about herbal kinds of preparations that can inhibit the iron's absorption. And of course, the safest action is to take mineral supplements only on the advice of your physician or healthcare provider, and only the length of time. Again, these can be toxic if they're taken in excess. Keep all of the substances and all medicines away from children. And acute iron intoxication is a common problem, and it can be fatal. Supervise children about using fluoride supplements and remind them to spit out oral rinses and gels rather than swallow them. And of course, keep follow-up appointments with physicians or healthcare providers to see how things are going, if they're, if we're maintaining that therapeutic, where we want to be, and also to check on adverse effects as well. Minerals are often contained in multivitamins, so we got to be sure to tell the patients to read their labels and find out about that. All right, now chelating agents for iron, copper, and zinc, and mercury. So chelating means that this is a medicine that is given in the event that there's an overdose or too much of the iron, copper, zinc, or mercury in the body. And the chelating means that it binds to metals and it enhances the excretion of the metal out of the body. Okay, so ferroxamine is used to remove excess iron from the body, and you can see that ferra is in the deferroxamine, so you should be able to recognize that as being iron. Okay, it is a perennial form, IM, IV, or sub-Q, and it turns the urine reddish brown. An adverse effect of that is anaphylaxis. So, we got to be careful about that. It can be used for iron overload also in patients who are having to get recurrent blood transfusion. There's a black box warning with it, risk of hepatic or renal impairment and GI hemorrhage too. The penicillamines are used for chelating copper, zinc, and mercury and lead to form soluble complexes that are excreted, and the succinimir is used for lead to form water-soluble complexes that are excreted in the urine. So, true or false, deferoxamine is chelating copper, zinc, mercury, and lead. Hopefully you said no, that's false. So that one is penicillamine. That will take care of all of those. Deferoxamine is for iron. Okay, so patient teaching protocols. So for oral supplements, we take or give at a preferred time and temperature when possible. Now we're going to talk a minute about oral nutritional products, nutritional supplement products, okay? And this would be like Boost or, you know, those liquid, usually liquid supplements that are out there for individuals. And they usually provide 1 kilocalorie per milliliter. And then we have enteral nutrition, which involves tubes that are involved. So enteral is tubes that are involved, or perennial nutrition is where there's an IV that's involved. Okay, so the tubes that are involved will either go from the nose to the stomach or through the mouth to the stomach, and the medicine is literally given through the tube, or we can have a tube that goes on, it's on the outside of the abdomen and goes straight to the stomach there. And so we can call those a gastrostomy tubes. The nasal gastric tube is the first one I was talking about. You also have a tube that goes down to the jejunum. So got different types of tubes that can be used for both nutrition and also to give medicines through as well. And so for tube feedings, we use or give with patients in a sitting position to decrease the risk of aspirating a formula into the lungs. So they need to be sitting upright if at all possible, at least 30 degrees or higher. Be sure that the place is correctly in the right place. And you'll learn all about this in your skills course as well as your 108 course also. Be sure that the solution that we put through the tube is at room temperature, because cold formula hitting the stomach like that can cause abdominal cramping. And we do not take or give more than 500 mLs per feeding, including 60 to 90 milliliters of water for flushing the tube. So after we give the tube feeding, we got to flush it with water to keep that tube clear, keep that line clear. And this helps with overfilling the stomach to keep it at that amount and possible vomiting. Take or give the medication slowly over a 30 to 60 minute period, because rapid administration can cause nausea and vomiting. And with continuous feedings, which sometimes you will see, the containers that the medicine, the feeding comes in, must be changed at least every 24 hours, and that's to keep down infection, because there's sugar in there, and it's will get warm, and just a perfect environment for organisms to grow. With intermittent feedings, we got to rinse all the equipment after each use and change it at least every 24 hours also. We've got to ask the healthcare provider about how much free water. So the patients will get water along with this. So we've got to find out how much we need to give, and that can be administered as well as the feeding with a pump that's designed special for the tube feedings. We've got to be sure we know and measure and document the amount of water that the patient does get. Also, we want to measure that output, urinary output that the patient's having as well, to make sure we're staying equal there. Give the medications by tubes. We give liquid preparations when that's available, and it may be necessary with medications. I'm sorry, this is medications by the tube. We'll give liquids. That's definitely much preferred. And we will have to crush the tablets, so you got to make sure that you got medications you can crush. No long acting or extended release medications or enteric coated can be crushed. So you got to make sure that when you're given these medicines, and then we mix it with 15 to 30 mLs of water and dissolve it, and then we give that water, and so we'll flush, then we give the medicines, then we flush after that, so that it doesn't clog up the tube. Okay, we don't mix the medicine with the tube feeding, the nutrition part. So we don't mix medicines with that because, it can affect the absorption. And we definitely want to flush the tube with water before and after the medications to keep that tubing patent. So you saw this on the previous slide. Again, we want to assess the patients for their current potential nutritional deficiencies, find out about what they've had in the last 24 hours, have them do a diet recall, and see what they're doing. Don't forget about asking how much liquids they're taking in as well, and also just appear, do they appear underweight? Are they able to eat? Are they able to cook? Are they able to chew the food? Do they have an appetite? Can they afford food? So, looking at all that, and then looking at your BMI, and anything again below 18.5 is going to be considered underweight and undernourished. So find out about the signs and symptoms the patient have, what kind of disease process, treatments, medications, or diagnostic tests that could be making the nutritional status not what it needs to be. With minerals, electrolytes, assessment factors, definitely we got to look at, the deficient states that are more common. So we got to see about those signs and symptoms, and also we got to look at our lab work on this as well. Many drugs influence gains and losses of minerals and electrolytes, like your diuretics or your laxatives. So we got to see about those. Are the patients on those? And what about, are they having any kind of suctioning going on through a nasogastric tube that would be causing them to lose minerals and electrolytes? Polyuria is, are they having excess urination? Poly meaning many, urea is urine. So, if we're urinating a whole lot, then we're losing electrolytes and minerals. Diarrhea is another thing that can cause us to do that, and excessive perspiration and sweating, and of course other conditions. Gotta look at the labs, okay? So the CBC, we're going to look at hemoglobin, hematocrit. We're going to look at values that can indicate iron deficiency, anemia. We're going to look at her electrolytes for sure, and looking at the sodium, potassium, chloride, the calcium, the bicarbonate. All of those you can get lab results of. We want to promote that well-balanced diet, 5 daily servings. We want, if they need an oral multivitamin, they may be that may be beneficial for them, but an adequate diet is your best if they can do it. And again, provide relief of symptoms, such as pain, nausea, vomiting, diarrhea. That's going to cause people not to want to eat. So if we can take care of some of those things, then we can try to get some fluid in them. And food in them. And we want to always promote exercise and activity as well. Again, minimize the use of sedative type drugs because they can't take it in if they're sleeping or if they're sedated. We want to weigh patients at daily if they're in the hospital care is what's typically done. And we want to monitor that weight, fluid intake, urine output, vital signs, blood glucose, and serum electrolytes, and complete blood count. Every how often they come to us, we need to be looking at them to see where we're at with the patient. Promote proper use of mineral supplements that are recommended only, for what is ordered or prescribed, because again, we can get excess and that can be a lot of problems there. As far as your tube feedings, follow the protocol with administration of ordered tube feeding products, and of course use best practice with that. We always have to check for tube placement to make sure we're in the right place, and maintain patency, meaning the tube is flowing like it should. It's not clogged up. Positioning of the patient, the head of bed has to be elevated. Prevention of aspiration, meaning we don't want that feeding or medications that we get through a tube to be going into the lungs. So that's why we keep them in the upright position there. And gravity or pump administration of the feeding products should be done, and then also the administration of free water and flushes. And also administer per protocol of the facility administration of medications through the feed tubing. And also with crushed medicines, you only do so if they are crushable. So you've got to make sure that is the case. Using liquid forms when they're available. And of course, irrigating to prevent the clogging up of the tube is going to be important for future use of that tube. All right. Thank you.